Welcome to the On Your Mind podcast, where we believe mental illness can be temporary and transformative. Stay tuned for innovative, effective tools from experts in the field of mental health. Hosted by Timothy J. Hayes, psychologist. This podcast aims to change the narrative around mental illness. Move from a place of fear to a place of hope and solutions. Here on Your Mind.
Martin Paul Whiteley is a mental health researcher, author, and was a Labour member of the Western Australian Legislative Assembly from February 2001 until he retired from state politics in March of 2013. During his parliamentary and research career, Whiteley has been a prominent critic of increasing child mental health medication prescribing rates. He has authored the book Overprescribing Madness: What's Driving Australia's Mental Health Epidemic, published in 2021. Essentially, it's a not-for-profit that hopes to help rewrite the narrative on mental health to one in which optimal health and well-being is possible and expected, and where mental health challenges can become transformational rather than tragic. So I'm donating my time to this group. I'm a psychologist in Illinois outside of Chicago, and the purpose of the podcast is to help share a message of someone like you and the research you've done and your perspective on certain aspects of mental health with our public, in our hopefully our growing population of people who are working to normalize the conversation about mental health and to look at things other than just medications to stomp out symptoms, but to look at the whole person, et cetera. So hopefully we'll help promote your work, and we'll promote the Journey's Dream vision and get more visits to their website and more visits for your people interested in reading your book.
Yeah. No, that's very much sounds like the sort of thing that we're trying to achieve, or some of us are trying to achieve in Australia, and that is less reliance on a sort of medicalised model and more of a holistic approach to mental health, and more of an optimistic approach that sort of abandons that permanent disability model that's inherent in documents like the DSM, and recognises that mental distress is often transitory and a natural response to what's going on in people's lives. But people do get better. Most people will get better.
Well, it's certainly been a blessing over this past year to interview people like this, people at Same Here Global, and a whole series of integrative psychiatrists and people who use functional medicine and the holistic approach rather than just chasing labels and symptoms. So, are you willing to talk to us about your book and what got you started on this journey?
Look, I've just written a book called Overprescribing Madness, which sort of tackles the issue of why 1 in 6 Australians is on some form of mental health drug. And the most common prescribed psychiatric medication in Australia is antidepressants. And most common of those is SSRIs, but with 1 in 6 Australians taking an antidepressant. Apart from Iceland, Australia were the highest users of antidepressants both in 2000 and 2015 of 33 OECD countries. And it doesn't really make a lot of sense when you look at the natural advantages we have in Australia, a functional society, a prosperous society, and by all reports, Australians self-report being a fundamentally happy people. I look at why is it that so many Australians have adopted a medicalised approach to distress and suffering, and there's a number of factors. One being, one of the chapters concentrates, or two of the chapters concentrate on the impact of Australia sort of adopting Australian psychiatry and Australian medical practice adopting the DSM model in an unquestioning fashion. I think it's probably the greatest example of cultural capture that you could cite, and it's not understood widely in Australia that we've actually outsourced the definition of who's sane and who's who's mentally ill to the American Psychiatric Association. And I think that's that unquestioning adoption of the DSM. And, there was a small debate around 2013 when DSM-5 replaced DSM-4, but nothing like the sort of debate that occurred in the US. And it simply passed into practice that would follow the DSM model. So that's one of the drivers. Another driver is we've got some homegrown, what I would say, psychiatric disease mongers who grossly inflate prevalence rates for psychiatric disorders, and end up with claims like, nearly one in two Australians will experience a diagnosable psychiatric condition, a serious diagnosable psychiatric condition at some stage in their life. I think we've had some influential key opinion leaders in Australia who have driven an even more medicalised model. Another problem that we have in Australia is that most mental health prescribing is done by general practitioners who have limited training in psychiatry and psychology, and basically have pills as their first and in many cases their only option. So the book, details, touches on those issues and others, and looks at it from an Australian perspective. But I think that the lessons that are in the book hopefully are equally relevant in other developed nations like the US and the UK.
So what prompted you to get into this? What's driving your passion for this work?
Well, initially I was a teacher in the 1990s in Perth, Western Australia, and Perth, outside of North America, had the highest rates of ADHD prescribing in the world at the time. And I was a teacher at a boys' school, and it was a very good school, very prosperous school, achieved fantastic academic results, but it had extraordinarily high rates of ADHD prescribing. And I was concerned I taught 12 to 17-year-old boys, and I was concerned at the number of boys that were on medication and on heavy doses of medication. And as a teacher, I couldn't see them benefiting from it. So I initially became concerned about ADHD. Then in 2001, I was elected to the West Australian Parliament. And as a member of Parliament for 12 years, I made driving down ADHD prescribing rates part of my focus. And then from my interest and knowledge of ADHD and concerns about overmedicalization of childhood behaviour, I sort of broadened out to become and saw similar patterns in things like the treatment of depression and the high rates of antidepressant prescribing in Australia. So I started to see consistent patterns of behaviour. So what started off as a fairly narrow interest as a teacher became a more broad interest in my time in politics. And since leaving politics in 2013, I've primarily worked as a mental health researcher and broadened my interest in mental health, still with a focus on ADHD prescribing as a major concern.
Well, you mentioned that the majority of people who are prescribing this are only primary care physicians, so they don't have a specialty in psychiatry or psychology. Yeah. So is there a movement in response to people like you and your book to try and shift that towards a wider array of possible interventions other than just medication?
Look, Australia does have a very good health system in the sense that we have universal access to low-cost primary care. So you can go to your general practitioner, and for people that are, for poor people, they can do it for at no cost, and for everyone else can do it at minimal costs. So what they've done is they've dovetailed the mental health system onto the back of the primary healthcare system. So what is in fact the strength has become a bit of a weakness in that they've strength for generalised healthcare has become weakness for mental health care, in that they've just simply linked mental health care to the primary healthcare system. And the model of healthcare in Australia is that you get a heavily government subsidised visit to the general practitioner, who is allocated roughly 15 minutes to see you. And in 15 minutes, general practitioners can't get to the crux of what's causing distress in people's lives. And hence, you've got this highly medicalised model. Also, pharmaceuticals are government sponsored. So not only is it the most readily accessible level of care, pharmaceutical responses are the cheapest response. So
for the consumer.
For the consumer, yes. So we need to tackle that systemic problem. Now, part of the problem is that when the bean counters look at what's the most efficient way of responding to mental health, well, a visit to a GP and a quick prescription, in terms of dealing with numbers of cases, is the fastest and superficially appears the most efficient way of dealing with the problem. But it doesn't actually take into account the fact is that you're in fact often exacerbating problems and making things worse, and you're causing repeat visits. So I think we need a more holistic approach to mental health, but we really do need in Australia to have a rethink about how we deliver mental health services, rather than just piggybacking onto the back of a health system, an otherwise functional health system. So there has been, on the positive note, one of the research projects I led looked at the relationship between antidepressant prescribing and youth suicide in Australia. Myself and some other researchers looked at the Australian response to the FDA's black box warning on antidepressant use that was issued in 2004 and 2007, and we found that since that immediately following that warning, there was a fall. Similar warnings issued in Australia, and there was a small fall in antidepressant prescribing to young people in Australia. Beginning in about 2009 onwards, there was a sort of a backlash where people argued against the worthiness of the FDA warnings, and since then there's been an upward spike, continuous growth in antidepressant prescribing to young people, and corresponding with that, there's been a significant rise in the suicide rates of people aged under 25. So that's bad news, but the good news is that our research actually instigated a review by the Australian government, who at last are taking the issue seriously. So there is an appetite for a less medicalised approach, but I think, and I'm speaking as a former politician, it's just the whole issue of mental health. People know that politicians and policymakers know that something needs to be done about it, but they just don't see simple answers. So those that are offering the simple answer of here's your tick box, approach to psychiatry as promoted through the DSM, and here's the pills that fix the problem. It's a simple solution. It has the superficial appeal of being a simple solution. So the problem for people like me is we have to compete with that, and we have to find ways that respond appropriately to people's concerns and distress.
Well, so it comes to mind to ask: have you read Robert Whitaker's book? Do you know about that book?
Yeah, I have. I'm familiar with it. Yeah, I dip in and out of it as I need to. It's a fantastic piece of work by a very good man.
So one of the things that comes out of a book like that is the realization that the blanket prescription of medications and the long-term prescription of these medications is causing more harm than good. So if you start there and you say, okay, we recognize that this thing that we thought was going to be a solution is actually creating more problems than it's solving, then hopefully it can give people a motivation to start looking to, okay, so what are some of the other solutions? And there isn't anything that's as quick and down and dirty as going to a doctor for 15 minutes and getting a pill.
Yeah.
But there are things that are far more effective that actually look at the cause and look at long-term outcomes that are based on looking at the whole person. They're based on an integrative psychiatric approach or a functional medicine approach. And I wonder, because I don't have any knowledge of what the therapy accessibility is in Australia. I do know that there was quite a bit of a movement in Australia for EFT tapping and the energy psychology movement doing, it wasn't exactly EFT tapping, but they had another name for it. They adopted the work of Gary Craig, and they had large EFT tapping down under. So can you talk a little bit about what is the level of access to therapists or alternative approaches in Australia?
Well, in terms of government supported access, there is a program. I mean, the standard, as I said, the standard response is you go to your general practitioner, your local doctor, who gives you 15 minutes and a pill, right? But there is a government funded program called Better Access, which enables visits to up to 10 and in some cases 20 visits to a psychologist a year. So in terms of mainstream access, government funded access to services, that's a new innovation, and it's a good innovation. But there are some concerns that in fact it's the worried well, in a sense. That's a term that's used, and I don't want to insult anybody with that, but people that are prosperous and are getting greater. The take-up rates in prosperous parts of Australia are actually higher for those government-funded psychological services than they are in less prosperous areas. But at least it is an attempt to move away from a totally sort of medicalised, pill-orientated approach to mental health. There are isolated efforts, and there are some very good practitioners and very good psychiatrists and very good psychologists. But in terms of a coordinated, organised movement, I'd have to say the efforts of people who think like we do are fairly amateurish, and aren't having a big impact. Just going back to Robert Whittaker's work and your observation in terms of global outcomes associated with rising rates of prescription. If I just go back to that piece of research we did on antidepressant prescribing in Australia, since 2009 in Australia, rates of antidepressant prescribing to people aged under 28 have risen by approximately, these are per capita rates, so after you adjust for population, have risen by approximately 66%. And over that same period of time, the rate of suicide for people aged under 25 has risen by 50%. So the per capita rate has risen by 50%. Now, interestingly, the people that argue that antidepressants are I'm going to put this in very simple terms, are a good thing for young people to use, often use the argument that, without antidepressants, we would have an increase in youth suicide. Well, in fact, the opposite has occurred. As antidepressant prescribing rates have increased, the rates of youth suicide have increased. Now, that's population data. It would be wonderful to have more specific, more case-specific data, so you could actually have a look at track individual stories, and hopefully some of the research that's happening in Australia is leading in that direction. But nonetheless, it's entirely consistent with that picture that Robert Whittaker paints of increased prescribing rates, increased treatment rates, and worse outcomes.
Right, and if they were working, if the medications were working according to the thesis that Robert Whittaker puts out there, then we would expect to see a decrease in all kinds of rates, including the percentage of people that go on mental health disability. But those rates have skyrocketed as the medication prescriptions have increased.
Yeah, and I think that's fundamental in the sort of DSM, American Psychiatric Association model that we've adopted in Australia. This model of permanent disability, and we've had some homegrown proponents of what I would argue is a permanent disability model. They would use different language. In fact, they sometimes, in my view, appropriate the language of recovery. But what they're doing is looking for new ways to find emerging mental illness in people. One of the big debates we had was DSM-5, and one of the small victories for people like us, I guess, was the removal of psychosis risk disorder from the draft of the DSM. Now we've got a homegrown proponent of that, Professor Patrick McGorry, who was Australian of the Year in 2010, and he's been incredibly influential in setting up a network of government-sponsored clinics in Australia that are basically one of the core functions of them is identifying those perceived to be at risk of becoming psychotic, those that are considered to be pre-psychotic and on a pathway towards schizophrenia. So whilst Professor McGorry would use different language, I'm critical of this approach because I think it's an extension of this permanent disability model. We're looking for new ways to define people as being disabled rather than looking for ways to support people to get well again. And, for some people, mental illness is and significant mental illness can be lifelong and can be completely disabling. But most people who are experiencing distress and even psychosis with appropriate support will recover and lead meaningful and happy lives, or even have intermittent episodes. But the model that we have adopted is one of permanent disability, whereby we've got this massive. I'm using the words of the others here, and I'm paraphrasing them. Those that I'm critical of, where we've got this massive unmet need, where all these people that are mentally ill that we just haven't recognised yet. And that, I think, is a real concern, and has been particularly influential in Australia through the work of people like Professor Patrick McGorry.
So the idea is it's a wonderful thing to do early identification and intervention, but if the intervention is just meds, you're in a real rut, because then the statistics and the research shows that if you start giving medications to those people with no other tools or intervention, you're probably going to ensure that they do have a progressive illness over time that gets worse and little hope of full recovery. Whereas if you have an assortment of tools and skills and early intervention, meds are often not needed or only needed for a short period of time. And the history of those people who have a depressive episode or even a psychotic episode, who are given support that is non-medication based, they get through it. And they don't have anywhere near as many relapses or periods of episodes of recurring depression or psychosis. So the question is, how in a place like Australia can you make those kinds of skills and tools that are already known? It's not like we have to go reinvent the wheel. There are many good things out there that help people through a mental health episode that have been known for decades.
Look, I think we need to do two things. We need to do exactly what you're saying, and that is provide alternatives of work. But even if we can't achieve that, first thing we need to do is stop doing things that make things worse. And there's plenty of evidence, as I said, with our response to suicide prevention in Australia, has, at least superficially, made things worse. The suicide rates of young people has spiked dramatically. In Australia, we've actually been very good at, and people like Professor McGorry and others that I could name have been very good at raising awareness of mental illness, and that we need to respond, and we need to recognise that people need support for mental health. But the assumption has been, and that's been picked up by the popular media, but the second part of the message has been, if you're unwell, don't ignore the symptoms, go and get help. And the underlying assumption in that message is that the help helps. But as is detailed in Robert Whitaker's book, and as I detailed in my book, the evidence is that in many cases, the help actually takes people backwards and is permanently disabling. And so I think it's great and we should try to build a system that helps people. But in the meantime, we need to have a second priority, and that is to stop doing the things that make people worse.
Right. We have to quit spraying napalm on the fire.
Yes, exactly. Yeah.
I had the pleasure of interviewing Beatrice Birch, who is an art therapist who founded Inner Fire in Vermont. And she was an art therapist over in Europe. And when she came back to America, she was just shocked to find that the people that they were dealing with in Europe, all the same kinds of diagnoses with almost no meds. And she came back here and every one of them has meds, and 2 and 3 and 4 meds. And she was just shocked at the system. And she worked in a hospital where the basic protocol was load people up with meds to try and stomp out the various symptoms, which of course every medication then has its own effects that are not so pleasant. And then sometimes you have to give 2 and 3 meds for the symptoms that are caused by the meds. And the crisis that she reached when so many of the people who connected with her personally and would ask her to help them get off the meds before she could make that happen, I forget how many of them, but a good number of them died of suicide. And that motivated her to get out of that system and start her own residential treatment center in Vermont. But the essence of the message is exactly what you said. At some level, we have to quit doing what we know only makes things worse.
Yeah. One of the things I argue in my book is that, as I said, 90% of antidepressants are prescribed by general practitioners in Australia. Now, they have limited mental health training, and they have virtually absolutely no training, the vast majority of them, how to deprescribe. And I don't think it's ethical or responsible for any clinician to prescribe a medication that they don't have the skills to help somebody withdraw from. And there's only just starting to be an awakening of, the dangers and the difficulties of withdrawing from common mental health drugs like, antidepressants. So I think there's an appetite for it. But the other thing that we need to realise is that when you're tackling this, you're tackling a behemoth. I mean, an incredibly well-resourced behemoth, and the efforts of people like ourselves, with all respect, are amateurish in comparison. I mean, the ADHD industry, for instance, global sales of ADHD medications this year will top $25 billion, with an and that rate is expected to double to $50 billion by 2030. Now, I've been involved in the ADHD debate for 30 years, and in terms of intellectual victories and the contest about the safety, the validity of the diagnosis and the safety of the drugs used to treat it, critics like myself and others have had continuous victories, and I'll talk about one of those in a moment. But none of this is impacted on prescribing rates. All around in America, they're out of control, but in Australia, places like Australia and Canada, and even places like Germany and India and all around the globe, rates of prescribing are going up. So despite the fact that the evidence base for the diagnosis and prescription of drugs for ADHD is getting weaker, the market is getting bigger. So that's an incredibly difficult problem to tackle when you've got the efforts of, there's no obvious economic base, for instance, for critics of ADHD prescribing. There's no way for a clinician who is skeptical about ADHD to become specialists in it. How do they earn an income? But those that actually amplify the voices of the industry are very well supported. It's, as I said, a $25 billion US industry now, and is anticipated to double in the next 10 years. And one of the victories I was talking about was the ADHD late birth date effect. Are you aware of what I'm talking about?
Say that a little more slowly. The ADHD what?
Late birthday effect, or the relative age effect. There's been a number of studies around the globe, including one that I led in Western Australia, but all around the globe, including the US, that have shown that children who are the youngest in their classroom are typically much more likely to be put on ADHD medication than the older children in their classroom. In Western Australia, the youngest children in class in a classroom are born in June. The oldest kids are born the previous July. And in Western Australian primary school children, that's children aged from 5 to 10, if you're born in June, you are twice as likely to be put on an ADHD medication as those born in July. Now, the obvious explanation is that you are younger and less mature. So you're perfectly normal.
Right. Your whole neurology is still developing. It's almost a year behind some of your classmates.
Yeah. And this happens the whole way around the globe. It happens in North America, it happens in Europe, it happens in Asia, it happens in Australia. I led a study that it was a systematic review of studies conducted around the globe, and it showed the same thing happens. And it doesn't matter whether it's a high prescribing jurisdiction like the US and Canada, where there are high rates of ADHD prescribing, or even some of the Scandinavian countries where rates are relatively low, very low in comparison. This relative risk remains. So the argument that there is a safe level of prescribing of ADHD medications whereby clinicians get it right, if we just reduced rates of prescribing, we would get it right, simply doesn't hold up. Even in countries like Finland, where they have relatively very low rates, in absolute terms of prescribing compared to the US, the relative age effect is still strong. So it sort of indicates that there's no. I think it's the clearest indication that's available that there is no safe level of ADHD prescribing where we can be confident that the clinicians have got it, the diagnosticians have got it right. So even when things like that come up, what happens is when we produced our paper, for a day or two, you get a round of media, and people go, "Tut, this is terrible. This shows that ADHD is a flawed diagnosis." But what happens is that you get your 1 or 2 days, in some cases maybe even a week of media, and it goes away. And the organised message of the ADHD industry, which is that ADHD is a common neurological condition that determined by genetics that affects 5 to 10% of the population, is continuously marketed. So when you're by this multi-billion-dollar industry, so it's very hard to compete with that. And I think you do the best that you can, but you need to be realistic about just what you're up against, and that is a very highly organised, highly profitable industry. And ADHD is one example of the power of big pharma.
Well, and I'm not one to tilt at windmills, so I like to put something out there that might help an individual who's looking either for themselves or a family member or a friend for what might be a viable alternative to just taking a pill. And that's what the Journey's Dream project is about, and this podcast has tried to do in the past year, is simply highlight people who've actually been trained in functional medicine approaches or in the holistic integrative psychology and psychiatry approaches, because there are so many good things out there that actually help a person learn how their body-mind system works together and learn to regulate the two sides of their system, the parasympathetic and the sympathetic nervous system. And with a little bit of education in that and a little bit of skill building, not everyone, but many people can move past an episode where they might have run to the doctor for a medication without any need of medication whatsoever. And I think that's where some of our biggest hope is, that if we can start to educate the people, then they don't keep running to the doctor. And again, like you said, it's a big challenge, because if you turn on your television here in America and you watch for a day, especially any kind of sporting events, you're going to see many advertisements for drugs. And many times you're going to be told, go ahead and ask your doctor for this.
Yeah. We don't allow free-to-air, we don't allow advertising on of medications direct to public in Australia.
Excellent.
So yeah, well, it is. And it's the few times I've been to the States, what I have been impressed about is the fact that they list all the side effects at the end of it. And I sort of think, well, really, why would you take Cymbalta if you knew it had all of those different side effects? But nonetheless, I think it's an insidious thing having direct advertising to consumers. But in Australia, what happens is we don't advertise the product, but we do advertise the disease. We have this massive push to create disease awareness, and often it's the ending message is this is an under-recognised condition. Go and see your doctor for help. Sometimes that's a paid message, and sometimes it's a very well-meaning
public service announcement. Yeah.
Yeah, and so there's marketing is probably a little more subtle, but nonetheless, it can be just as effective. And whilst rates of antidepressant prescribing in Australia are comparable with the US, and other rates like ADHD prescribing are concerning and high, but nowhere near as high as the US. But I think in Australia and many countries around the world, we're just a matter of years behind. We're following the US lead, which is unfortunate. And I think there will come a global tipping point when people do realise that fundamental message that is in Robert Whittaker's book, that the more we do, the worse. In many cases, the worse things have got, and the answer isn't as simple as a label and a pill. I think there's an appetite for that message. I know, as someone who's prominent in the media in Australia, it's easier to get that message into mainstream papers. Journalists are more receptive to it. And in a sense, as the worse things get, the more obvious it becomes that there's a problem. So I think there will become a cultural tipping point whereby not only we stop doing the things that harm us, we'll be more receptive as a society to the sorts of things you're talking about, the things that actually can help us. But there's a big fight to be had before that happens.
Well, and I'm hoping that the groundswell picks up momentum. People like Dr. Jody Skillicorn, who got her medical degree and was practicing as a psychiatrist, and then she ran into Robert Whittaker's book, and she read it and she said, oh, wait a minute, they didn't teach me this in medical school. They didn't show me all of this data on how this is causing more problems than it's solving. And so she then had to re-educate herself and get some, integrative and functional medicine training and find out how she could help people that come to her in ways other than just prescribing the meds, which now she knows from the research is a non-answer, right? It's a compounding problem, not a solution.
Yeah.
And there's the same here, global.org website, where they're trying to pull together this realization at a grassroots level that, mental health episodes and issues affect far more than just 1 in 5 people. And there are things to do other than just take a pill for it or chase the symptoms. Learn at a systemic level how your mind and body work together and the tools and skills you can learn to change your life for the better. And eventually the hope is enough of those doctors, and there are a list of psychologists and psychiatrists and other practitioners who have awakened to the fact that what they were taught in their medical school training and their psychologist training was woefully lacking in usefulness in day-to-day experience with patients. And so the more that happens, the more people find out about it, the more they're likely to ask their provider, whether it's a medical doctor or their psychologist or psychiatrist, is there something I can do instead of a medication? And hopefully that'll start to turn the tide.
I think it's been both pleasing and disappointing has been the response of most. I've been surprised how many psychiatrists and paediatricians, particularly in response to ADHD, actually are very sympathetic to the sorts of things we're saying. I would suggest that most of the psychiatrists that I encounter in Australia actually, in broad, not in detail, but in broad terms, would agree with most of what we're saying. But unfortunately, it's not the majority that do the majority of damage. Like one of the things that I was most proud of that I did when I was in politics was to actually tighten up prescribing accountability measures for ADHD. Prior to me coming into politics, Western Australia, Perth had the highest, outside of North America, had the highest rates of prescribing in the world. And but the local ADHD industry was in denial. It said, no, we're just in line with worldwide practices, and everything's done responsibly. When we put a tightened up prescribing accountability measures and started to produce annual reports, we found that one particular paediatrician in Perth had prescribed to 2,077 children in a 17-month period. And that the vast majority of ADHD prescribing, something like 90% plus, was being done by a Perth's a city of about 2 million people. Probably San Diego would be sort of equivalent city. But the vast majority was done by a handful of prescribers. So whilst many of the other, and it was primarily paediatricians, whilst many of the other paediatricians would privately agree with me, they abandoned the field. They left this I would call it a lunatic fringe of prescribers, take over and dominate mainstream practice. So I think there is actually more support in terms of professional support within psychiatry and within the medical profession than currently gets a hearing. But of course, those that are most motivated and earn the biggest income and frankly are the best resourced become the loudest voices in this area and dominate the debate. So I think there are reasons to be hopeful that there is room for a sort of a broader coalition, but the disappointing aspect is how quiet they have been and how polite they have been in their criticisms of their peers. I think it takes, people have mistakenly said to me that the work I do is courageous. Well, it's not. I mean, I was a teacher, then a politician, and now a researcher who's never depended on livelihood, has never depended upon not insulting mainstream medical practice. Whereas many of these doctors say, look, I wish I could do practice in another way, but the system is orientated towards doing this way. And in fact, there's an absurd situation in Australia where some general practitioners feel pressured to prescribe antidepressants to young people that come into their surgeries, because if anything goes wrong and they haven't done anything, the fear is that they'll be held professionally responsible. So, we need to amplify the voices of what I think are actually mainstream voices within and more common sense voices within the medical profession and within psychiatry that are actually critical of this sort of pill for every ill approach. But it's hard to do that when you don't have that, $1 billion resource base that the pharmaceutical industry has. That's a challenge, but there is some room for optimism, I think.
Well, I'm glad to have someone like you out there writing about it on another continent, and I'm honored that you would take the time to share this time to interview with us today. The book again is, give us the full title, please.
It's called Overprescribing Madness: What's Driving Australia's Mental Illness Epidemic. So if they to Google Overprescribing Madness, that'd take you to the book.
Yeah, and it comes up right away with you, Martin Whiteley, as the author, and I appreciate it so much for your time and all the work you're doing to try and bring awareness to this critical issue.
And thank you for reaching out and the work that you do.
Well, if you get another book out, we'll have you back and we'll talk about it. And
about once every decade, I write a book.
All right, we'll see if we're still around.
Due in 2030.
All right. Well, hopefully by then we will not have lived into the prophecy that you'll double the prescribing rates. Yeah.
Yeah. I hope so.
All right. Well, thank you so much for your time, sir, especially for taking the time to be so early in the morning. It's appreciated.
Thank you. Thank you. My pleasure.
Martin Paul Whiteley is a mental health researcher, author, and was a Labour member of the Western Australian Legislative Assembly from February 2001 until he retired from state politics in March of 2013. During his parliamentary and research career, Whiteley has been a prominent critic of increasing child mental health medication prescribing rates. He has authored the book Overprescribing Madness: What's Driving Australia's Mental Health Epidemic, published in 2021. While still in politics, Whiteley wrote, Speed Up and Sit Still: The Controversies of ADHD Diagnosis and Treatment, from UWA Publishing 2010. Since retiring from politics, he composed a PhD thesis titled ADHD Policy, Practice and Regulatory Capture in Australia, 1992 to 2012. Subsequently, he has researched Australian mental health policy and practice and pharmaceutical and medical device regulation. His research has primarily focused on the drivers and outcomes of prescription mental health medication use by children, adolescents, and young adults for the ADHD diagnosis and depression. He has authored the book Overprescribing Madness: What's Driving Australia's Mental Health Epidemic, published in 2021.
You've been listening to the On Your Mind podcast, offered by Journey's Dream, where we support people through mental health challenges to a place of true and lasting well-being. If you love our show, we invite you to visit onyourmindpodcast.org to join the conversation, access the show notes, and discover our helpful resources. Thank you for listening.